Hey guys, welcome to this segment on the assessment of the OB patient. We know that the assessment with the OB patient is going to be performed primarily, at least, like any other patient, any other non-OB patient. We start off with our scene size up, however, paying close attention to the number of patients we have, knowing that that can change in any moment. Our focus then switched from scene size up to a primary assessment. The primary assessment, focusing on airway, breathing, and circulation, should remain the same as it would for any non-OB patient. We will, however, pay special attention to the developing fetus. We also know that history taking becomes an extremely important part of this as well. We're going to go ahead and pay attention and gather the necessary information to complete our sample history. We're going to gather information about the pregnancy itself. We're going to find out whether the patient has any type of cesarean sections or any other gynecological or obstetric emergency previously, whether they've had appropriate prenatal care, taking prenatal vitamins, seeing their doctor regularly, and whether or not they've had any type of ultrasound or sonogram done to determine gestation of the child, if the great vessels are in the right location, things of that nature. There are some key areas that we're going to focus in on in this assessment for our OB patient, and those include things like diabetic emergencies or diabetic related illnesses or pre-existing issues or conditions, and cardiac related issues because of the amount of physiological changes that happen in the body. We know that the body is going to increase its blood supply, its circulating blood volume, by up to 50%. That is an enormous impact on the patient who has pre-existing conditions with things like hypertension or cardiac disease. And we also know that if they have a history of diabetes, that they can become unstable during pregnancy. Diabetes is one of those big things that leads to an increased risk in preeclampsia and the onset of hypertension. And we know that most of the time pregnancy may accelerate these progression of these vascular diseases and complications that happen because of diabetes as well. So they're closely tied together. We know that it's not uncommon for pregnant patients who are diabetic to have problems with fluctuating levels of their blood sugar. That can be either hyperglycemic or hypoglycemic episodes. Most patients who develop diabetes during pregnancy have a pre-existing condition like diabetes normally, but that's not to say that it can't happen without a history. In the case where we have the onset of diabetes during pregnancy, we call that gestational diabetes. And we know that any patient who has a history of diabetes and is pregnant is most likely going to be placed on insulin to help control that rise and fall of sugar. Now, focusing primarily again on the diabetic mother, we know that infants of the diabetic mother tend to be large. More sugar available means more rapid cellular production, leads to a larger fetus, larger newborn. That leads to complications during delivery. For example, where the baby may not be able to be delivered in a normal vaginal birth because it is too large. It may have to come out by a C-section. We also know that infants who have diabetic mothers may have a more difficult time regulating their blood sugar and body temperature after delivery. So these are complications as part of our primary assessment of our neonate that we need to be very closely aware of. Babies that are born to diabetic mothers are also at an increase for congenital abnormalities. So we want to try to get a good history if any type of diabetic problems have been in the mix. Now let's switch gears a little bit more towards the cardiovascular side. We know that during pregnancy, our blood volume is going to increase by about 50%. So that means we're going to have 50% more circulating blood volume than we normally would. That leads to a number of changes physiologically. Patients who have existing conditions like heart disease can develop heart failure. Those who have hypertension, we know that hypertension can be aggravated by the increase in blood volume. And we may have underlying conditions that arise like preeclampsia that can contribute to that maternal hypertension. Persistent hypertension, though, will compromise the fetus. We have to remember that mom is a host, and she's supplying the blood and nutrients and oxygenation that's necessary for that fetus to grow and to develop. So anytime mom is at risk for a stroke, seizure, or any type of renal failure, we know it's going to have a complication on the unborn child. Women who have poorly controlled seizure diagnosis are likely to have an increased seizure activity during pregnancy as well. And most of the time, they're not able to take their underlying prescriptions that they would normally have if they have a seizure issue. Things to kind of keep in mind. If they have any type of neurological or neuromuscular disorders, they can be aggravated by pregnancy. We know that the hormones that are released during pregnancy cause your ligaments to relax and to allow for some more stretching of the pelvis itself. Pain is oftentimes can be all over the place when it comes to pregnancy. If they're in pain, we want to determine when it started. Was the onset sudden or gradual? How has the duration been? How long has it been going on? Where is the pain located? And where does it radiate to? We also want to pay close attention to our OB patients to see if there's any presence of vaginal bleeding or spotting. That becomes a major concern in our OB patient. Key things to assess for include color, amount of discharge, duration, how long it's been discharging, and what were they doing before the bleeding started. We want to keep a close contact on how many sanitary pads they've used or tampons, because we want to try to be able to estimate the amount of blood loss that they've had. We also want to know, have they been passing any type of clot or tissue, and if there's any of that that's present at the scene, that we do our best to try to save that for evaluation at the hospital. Now, your assessment for a patient who's in active labor, we're first going to assess whether the mother feels the need to push or has the urge to move her bowels. If that's the case, prepare for delivery. It's going to be imminent. We want to determine, though, did the membranes rupture? Did her patient's water break? Remember, that's going to be the pre-lubrication that's going to allow for the child to pass through the birth canal. Now, primarily, that's going to be a lot of questions in regards to your history, medical history, things of that nature. Now we're going to focus primarily on the physical exam. The physical exam, same for every emergent patient. We're going to start in a process that's going to be head to toe or focus in on an area that's important. We want to protect the patient's modesty as much as we possibly can, maintaining their dignity and their privacy. So we don't want to be having everybody seeing everything if it's not necessary. Keep in mind where you're doing your assessment and who's around. We also want to know what's the estimated date of pregnancy. We do so by measuring the fundal height. We do that from the base of the fundus, from the pubic symphysis up to the top of the fundus. That's measured in centimeters. Each centimeter correlates to approximately 1 week of gestation, so we can have an idea on that. It is important to know that not every parent, or mother I should say, will actually know their gestation, so you may actually have to be creative when it comes to measuring this. We also want to make sure that we're getting appropriate vital signs as part of our assessment. However, we don't want our patient laying supine. Laying flat on their back can cause supine hypotension syndrome. So when we take vital signs to get an accurate reading, we want to make sure that the patient's lying on her left side. This is primarily so in the second and third trimesters for sure. Other things that we need to know, we may have to actually expose and examine the genitals to evaluate for vaginal discharge, progression of labor, to see if we have any signs of crowning, or if there's any presence of a prolapsed cord, where the cord is actually coming out before the child. We're going to have to do that. So we're going to need to examine the peritoneum. This only needs to be reserved for cases where we really need to look. This is not something that we do an assessment on every patient who potentially may be having complications. We're talking about patients who have active discharge, active bleeding, active signs of labor. Those are the patients where we need to perform that peritoneum exam. One of the big things we're looking for, as I mentioned earlier, is crowning. Crowning is bulging of the fetal head past the vaginal opening during a contraction. We can actually see the child begin to crown. That's an indication of impending delivery, and that we need to make sure that we're prepared to stay and play as we prepare to deliver this child. We also want to make sure that we only examine crowning primarily or focusing it on crowning during a contraction. You're not necessarily going to see crowning without a contraction present because it takes a lot of force for those muscles to expel that fetus. We never perform any type of internal vaginal examination in the field. We don't determine if the cervix is dilated or to what extent. The only time that we will insert any appendage into the female patient who's suffering from an OB emergency is to help maintain the life of that fetus, and that includes things like a nuchal cord, an area where we're having a breech delivery, where the head is now trapped or the cord is crushed, and we need to provide a lifeline for the fetus. Those will be the only times. Couple key things to remember. Remember that you're not caring just for one patient, you're actually caring for two or more. That's the mom and the fetus. We know that fetal well-being is dependent on maternal well-being. Remember, mom's a host. So if mom is showing signs of distress, we know baby is in distress. And oftentimes, if mom is showing minor to no signs of distress, the child can still be in distress. So we need to make sure we take that seriously. We need to keep mom as stable as she can, providing her oxygen, even if we're not sure if we need it or not. Being able to provide it is going to give her that opportunity for more oxygenation to get to the fetus. We got to keep that relationship of host and fetus in mind. We also need to make sure that in a chaotic situation, as childbirth is, that we maintain a calm, professional demeanor and a caring attitude. We have to make sure that those things are at the forefront of what we do. And then protect the patient's privacy as much as we can, again, maintaining her modesty. Maintain their airway, breathing and circulation, administer oxygen if needed to correct any type of hypoxia. Remember that mom may not show signs of distress because of her increase in blood volume and red blood cells. However, the fetus may be in distress. We need to initiate IV access, large bore catheters in a large vein, preferably for large fluid resuscitation. We'll typically do that at that 20 mLs per kilogram fluid bolus, up to 1 to 2 liters of fluid if necessary, based on local protocols. And then make sure that you're managing the patient's, performing cardiac monitoring to interpret any type of cardiac arrhythmias. Make sure the patient's comfort, stuff and fluff technique cannot be more important in this case. And if pain is a primary complaint, go ahead and administer analgesics. You can do so with caution. Just make sure they're appropriate based on the situation. You consult with medical control when appropriate, and we try to make them comfortable. We're going to transport a patient immediately to the hospital. It's going to be capable of managing specific OB emergencies and neonatal care. And those are some of the core things that we think of. Key things to remember, we're dealing with more than one patient. If mom is in distress, baby is already in distress and at a more severe level, and that the majority of the time things go normally, and our history is going to be the biggest attribute that we're going to be able to use to guide our treatment. So that's our overview for management of an obstetric patient.